there is a link. The data are pretty poor. The link is not a direct link between sleep and breast cancer. The link is indirect. So we know from a lifestyle standpoint that people who do not sleep enough and people who have poor quality of sleep can have some disturbance in their hormones. And the types of disturbance that they can have can give rise to insulin resistance. Now, you've heard of that. Insulin resistance is sort of like a pre-diabetes condition. It's associated maybe even with some increased weight. And these are the factors that correlate with the prevalence and incidence of breast cancer when they look at big bodies of data. And what you should take home from that is that if you recognize you're having some problems with sleep, either before a diagnosis of breast cancer just to be healthy, or after a diagnosis because it can impact the clinical course, there are some interventions to help out.
So let's ask the tough question. What is inadequate sleep?
So from a quantity standpoint, it's about 7 hours plus or minus. And really that's something that you can do. And there are some tips to help you sleep. I'm going to give you just one tip. How many people worry, and as a result of worrying, would say that they don't sleep well? Many people? All right, so only a few. So one of the tips would be to schedule worry time. Right? Sounds kind of weird, but it works. There's evidence. You schedule worry time. You allot a certain amount of time during the day, maybe in the afternoon or the early evening, kind of lock yourself in that room of yours, and you get a piece of paper and you just worry. You just worry and worry and worry. And after about 30 minutes of worrying, you're done. And people tend to sleep better.
I'm happy to say, and with great confidence can tell you, implants absolutely do not cause cancer. And in the hands of expert mammographers and breast surgeons and oncologists, absolutely do not prevent the detection of a cancer. In the late 1980s, there was a scare about silicone implants, and it was based on a lot of hearsay, but it led to a wonderful amount of science, which was performed in the 1990s. During which time a great number of epidemiologic studies were performed and proved emphatically that implants are indeed safe. They're safe to utilize in a cosmetic sense and setting, and they are especially safe to use in a reconstructive setting. So we're quite mindful of the debates in the past. We understand what led to it. We understand that people can still be fearful, but again, in the hands of expert mammographers, implants in cosmetic cases are not dangerous whatsoever. And as a tool in reconstructive breast surgery, they are extraordinarily powerful at restoring form, contour, and confidence in women who unfortunately require mastectomies.
What I do in my office all day long, obviously with women newly diagnosed with breast cancer, is walk them through this process and help them answer this one question: lumpectomy or mastectomy. And for most women diagnosed with breast cancer, the surgeon is the first, and surgery is the first line of treatment. And so this is the first decision-making juncture in the decision-making tree. And absolutely, there are things, medical parts of this equation, that make me as the doctor recommend one over the other, but most women really do have the choice. And so much of our work with our patients is collaborating on this decision making, which is really one of the most enriching and fulfilling parts of what we do, which is working with our patients in a collaborative way to decide what the best treatment is for them. The single most important piece of data that women need to make their decision is the answer to this question, which is for women who are eligible for both lumpectomy and mastectomy, there's absolutely no difference in long-term survival. And exactly what Perry said, it's so counterintuitive that doing more extensive surgery wouldn't lead to higher survival, but it's absolutely not true. When, God forbid, breast cancer comes back, which thankfully it does not in most cases, breast cancer usually spreads to the body and organs in the body. It does not usually return in the other breast, and certainly not in the other breast. So removing more healthy breast tissue besides the area of the cancer really doesn't provide any benefit in terms of breast cancer survival. Now, absolutely there are cases where we recommend one over the other. And many of you know some of these cases. There are plenty of people, for example, who have the BRCA mutation and are genetically predisposed. And if you perform a lumpectomy on that person's at extremely high risk for having a second event and even a third. And those are people where we very much preferentially recommend mastectomy, bilateral mastectomy. There's absolutely cases where we try to do a lumpectomy and can't get clear margins and get all of the cancer out. And that's a situation where medically it is beneficial to do a mastectomy, and many women choose to remove their other breasts. But for women who have the choice, the survival rate is equal. And that's the key fact in decision making and the key starting point.
What we actually have looked at is a very serious topic, because while breast cancer is extremely serious and is feared by many women, actually more women die of heart disease. The same age range of people that are at risk for breast cancer are also at risk for the earliest development of heart disease and the development of heart disease. So if we step back a minute and we think about how do we get heart disease? You get heart disease, you get strokes because the vessels get diseased. We have vessels that go throughout our entire body, including in our breasts. So the mammograms are exquisitely designed to look for calcifications. Those calcifications are hardening of the arteries in the breast. They can also be breast cancer, and we can very easily tell the two. So historically, radiologists have been told, don't mention that. It's kind of not your purview. Don't worry about it. But what we decided to do was make the woman, not the breast, the focus of our attention. So we have been reporting the status of the breast arteries on mammography. And when we look at that and we compare it to the status of coronary arteries, and we compare it to standard risk factor calculations for heart disease like diabetes and hypertension, it's actually a 70% correlation, so that if you have calcified vessels on your mammogram, there's about a 70% chance that your coronary arteries are also calcified, which puts you at an elevated risk for having a heart attack. And there are things that can be done. Maybe you need a worry room, or maybe you need statins or something, but there are preventive strategies that can be done for heart disease, and so it's important to know about it.
Immunotherapy is probably the most exciting thing going on in medical oncology today. There's several types of immunotherapy, and one type is a vaccine. So vaccines are basically taking a tiny amount of a protein that's expressed on a breast cancer cell in combination with medications that stimulate the immune system. So that, similar to the way we undergo vaccinations to prevent infection, giving these tiny amount of protein allows the patient's body to mount an immune response to those cells and recognize those cells as different from normal cells. So we currently are excited that we have 3 vaccine trials open at the Dubin Center for several different subtypes of breast cancer. And these are for patients with early stage disease. After they complete all of the standard therapy, we're able to offer these vaccines. So we have a vaccine for patients who have what's called triple-negative breast cancer, where they don't have any of the hormone receptors or the HER2 protein. And we also have vaccine trials open for patients who have HER2 neu positive and HER2 neu negative breast cancer. And we're the only site in Manhattan that has these vaccine trials, and so we're putting lots of patients on the trial. We're very excited about this. The other important type of immunotherapy to mention that have been in the news a lot lately are what are called checkpoint inhibitors. And basically, at this point in time, those drugs are being looked at in more advanced cancer, but the way things work in oncology in general, if things are found to be effective in advanced cancer, we then move them into earlier stage disease. So what checkpoint inhibitors are is that the cancer cells actually tell the body to shut down the immune system so that the patient's own immune system can't recognize those cells as different from normal cells. And what these checkpoint inhibitors do is they allow the body to release that molecular brake that the cancer puts on the immune system. So they inhibit that shutting down of the immune system and are able to unleash the patient's own immune system to fight the cancer cells. And these are amazing drugs. They're currently FDA approved in advanced lung, lymphoma, bladder, kidney cancer. There's some early evidence in certain types of breast cancer that these drugs have effects as well. And so those are in clinical trials. These drugs are able to produce sometimes durable remissions in patients who really are not responding to other therapies, unlike things that we've seen, for example, melanoma, which used to be an absolutely devastating advanced melanoma. Patients now go into remissions that last for many years with these drugs. We're excited to find out that we just got funding for a study combining chemotherapy with one of these checkpoint inhibitors in patients with advanced breast cancer. So we'll be opening that soon.
The short answer is you can get pregnant after you've had breast cancer. One of the things we're doing at Mount Sinai is we've created this Onco Fertility Clinic, which is a partnership between our department and Dr. Port and some others. And basically what we're going to do is offer a place for men and women who are diagnosed, who have these questions, to get the answers before they start their treatment, because some of the treatment options do involve this is in the equation. And so we're very proud of this. We're just getting it off the ground. And so there are a lot of different kinds of cancers and a lot of different kinds of chemotherapy. And so some you can, some you can't. And so it's very individualized, and it's a very complex world out there with a lot of different chemotherapies. And so these experts are going to sit down with anybody who wants to hear this, and they will get that information for their specific disease in their specific circumstance.